is over the neuro-ophthalmic side effects of systemic medications. So what is a neurological side effect? Anything that affects the nervous system, whether central or peripheral, can result in a neuroside effect. The central nervous system is made up of the brain and the spinal cord. The peripheral nervous system is made up of nerves that leave the central nervous system and go to other areas of the body. It's when these nerves go offline that you're going to have the problems. If they go offline, then the nerves can't do what they're supposed to do. Some of the things that make it go offline are shown here: compression, trauma, degeneration, ischemic events, toxicity, infection, drug overdose, congenital defects, and this list can go on and on. Symptoms that result from this can be both physical and emotional. A larger list of side effects will be listed on the next slide, but we wanted to point out here that some emotional side effects are important to make note of, because these emotional side effects can be signs of an early neurological problem. Here is a compiled list of the neuro side effects: partial or complete paralysis, muscle weakness, sensation loss, seizures, difficulty reading or writing, poor cognitive function, pain, decreased alertness, aphasia, headaches, blurred vision, fatigue, behavioral or coordination change, slurred speech, and tremors are all good examples of a neuro side effect. It's important to understand that if an individual experiences these, that they should seek out medical care right away, because it could be something important that's causing them. It's also important for a physician to know their brain anatomy, because if there is a lesion in the brain, it can lead to certain symptoms, and it's important to pick up on that. It's notable here also that the drugs that we're going to be talking about in our presentation are mostly working at the level of the neuromuscular junction, and these won't have the ability to penetrate the CNS because they can't get through the blood-brain barrier. So here are the medications that we're going to specifically be talking about in our presentation. Ethambutol and amiodarone both cause optic neuropathy. Tiopronin, calcium channel blockers, and penicillamine all cause myasthenia-like syndrome. Tetracyclines can cause pseudotumor cerebri. Haloperidol can constrict the pupils, and immortal creams can dilate the pupils. The first drug is ethambutol. Ethambutol is an antimicrobacterial agent that's used in the first-line treatment of tuberculosis. Tuberculosis is a microbacterial infection that mainly attacks the lungs, but can go anywhere in the body. Some common organs that it can affect besides the lungs include the brain, the spinal cord, and the kidneys. The most common symptom to pick up on with this is going to be the hemoptysis, or coughing up blood. There are other symptoms that come along with this, and those include pain upon respiration, fever, fatigue, and there are other specific symptoms that can arise depending upon which organ is affected, and we don't have the time to get into that. The mechanism of action for ethambutol is not fully understood, but thought to interfere with the cell wall synthesis of the mycobacterium. The specific side effect is toxic optic neuropathy, and for these toxic neuropathies, they're all going to be dose dependent, and they're going to be bilateral, so they're going to cause decreased vision in both eyes, and they're going to cause some color vision changes, specifically some blue-yellow color changes, and the color changes are just called dyschromatopsia. The pathophysiology for ethambutol is unknown. However, we do know that there will be some regression of the neuropathy if a practitioner catches it soon enough and they reduce the dose accordingly. The dose that the physician will typically start on a patient is 25 milligrams per kilogram per day. However, once that neuropathy is noticed, they reduce it down to about 15 milligrams per kilogram per day. Also of note is the neuropathy is most often retrobulbar, so you won't notice it on a normal fundus exam. The neuropathy usually comes about between 3 and 6 months of treatment on average. Also, the practitioners that prescribe the ethambutol are going to practice directly observed therapy, meaning that they're going to have to physically watch the patient take the medication to guarantee compliance, and this is actually enforced by law. The second drug here is amiodarone. There are 4 classes of drugs that treat arrhythmia. And of the 4 classes, amiodarone falls into class 3, the potassium channel blockers. It treats arrhythmia, specifically atrial and ventricular fibrillation and tachycardia. Amiodarone is actually the most common prescribed antiarrhythmia drug today. It works by extending the refractive period of the heartbeat by prolonging its action potential. This drug has a few different side effects. The 2 neurological side effects are going to be toxic optic neuropathy and non-arteritic anterior ischemic optic neuropathy. It's important to distinguish the 2 of these because it can determine how you treat this condition. So, like we said before with ethambutol, the toxic neuropathy is going to be bilateral. And to go into a little bit more detail here, the visual field defects are going to be secocentral. It has a slower onset, and it's also dose dependent, as said before. The non-arteritic is going to be unilateral. It produces altitudinal defects, and it has a sudden onset. And with these, you can actually treat it with corticosteroids, and that will actually cause some regression of that as well. The pathophysiology is unknown, but it is thought to disrupt the lipid metabolism. With the toxicity, there will be regression if you catch it soon enough, and the practitioners or cardiologists that prescribe the amiodarone will actually change the medication to stop that. Coming back to the ophthalmic side effects, the neuropathies are not the most common side effect from this. It's actually a corneal finding called whorl keratopathy that's most common with amiodarone, and this is just a finding. It won't affect vision in any way. Tiopronin is the next drug on our list. It falls into the drug class of genitourinary tract agents. It can be used to treat a few different conditions: cystinuria, Wilson's disease, and in rare cases, rheumatoid arthritis. It is primarily used to treat cystinuria. This is when there's a stone formation made from the amino acid cysteine when it cannot be excreted from the body. The stones can form within the kidney, the ureter, and the bladder. Wilson's disease is when there's an accumulation of copper within the liver and brain. This disease also has an ocular finding called a Kaiser-Fleischer ring, in which the copper accumulates within the cornea itself. The mechanism of action for tiopronin is that it's a reducing agent that undergoes a disulfide exchange with cysteine in order to form tiopronin cysteine, which is more easily excreted by the body. The ophthalmic side effect here is a myasthenia-like syndrome, which basically mimics myasthenia gravis. Myasthenia gravis is an autoimmune neuromuscular disease in which antibodies develop and block acetylcholine receptors within the neuromuscular junction, inhibiting excitatory effects. This results in muscle weakness. Myasthenia-like syndrome does the same thing, except that the drug blocks the acetylcholine receptors, and that's what causes the weakness and fatigability. When these signs are noticed, the physician will cease the medication immediately, and then all of the symptoms will regress.
The next drugs that could cause neuro-ophthalmic side effects are calcium channel blockers. Drugs in this class include verapamil, nifedipine, amlodipine. They treat vasospastic angina. Vasospastic angina is caused by ischemia to the myocardium tissues of the heart due to vascular spasms. Symptoms include shortness of breath and chest pain. Calcium channel blockers work by interfering with calcium entry through voltage-gated calcium channels on the presynaptic side, and they can also slow the recovery of these channels. It can be long-acting or transient. The ophthalmic side effect is myasthenia gravis-like syndrome. Matt already covered how that works, but it's characterized by weakness and fatigability of voluntary muscles, and patients can commonly report ptosis or double vision from transient bouts of cranial nerve palsies. The way that calcium channel blockers work to induce myasthenia gravis-like syndrome is calcium is required for the presynaptic cleft to release acetylcholine from its vesicles. If calcium movement is blocked, acetylcholine will not reach the postsynaptic cleft because the vesicles were never released. If you couple that with the destruction of acetylcholine receptors, this could lead to fatigue and paralysis. The last drug on our list to cause myasthenia gravis-like syndrome is penicillamine. Penicillamine is a disease-modifying anti-rheumatic drug, or DMARD. It treats rheumatoid arthritis. Rheumatoid arthritis is characterized by inflammation. It's an autoimmune disorder. It affects the small joints in the hands and the feet. The lining of the joints become inflamed, resulting in bone erosion and joint deformity. Patients will experience swollen, stiff joints, and sometimes bumps under the skin, and they can also fatigue easily. The way that penicillamine works is a number of things. It can reduce numbers of T lymphocytes, inhibit macrophage function, it can decrease rheumatoid factor, and it prevents collagen from cross-linking. It also is used as a chelating agent, and that's removal of toxic metals from the body, such as copper in Wilson's disease. And we've already talked about myasthenia gravis, but the way that it works is some sources say that chelation therapy can cause a decrease in calcium, while other sources say penicillamine specifically has no effect on the excretion of calcium in patients with rheumatoid arthritis. There's not much in the literature about how penicillamine causes these myasthenia-like symptoms. If it is a decrease in calcium, it would be similar to calcium channel blockers in that they decrease acetylcholine release at the presynaptic cleft. The next drugs on the list are tetracyclines. Tetracyclines include doxycycline, minocycline, and tigecycline. It obviously treats bacterial infections. It is broad spectrum, so it treats both gram-negative and gram-positive. It can be used for Lyme disease if given within 72 hours of the bite. It's used to treat cholera and chlamydia infections. We as optometrists might use it to treat meibomian gland dysfunction, and it can also be used to treat acne. Unfortunately, resistance of bacteria to tetracyclines is on the rise, and if it's resistant to doxy, then it's resistant to all drugs in the class. You do not want to give doxy to patients who are taking warfarin, as it will result in death. The way that it works is it reversibly binds the 30S ribosomal subunit, preventing binding of the tRNA. This prevents the addition of new amino acids to growing peptide chains. This inhibits protein synthesis. The ophthalmic side effect is pseudotumor cerebri. It affects overweight, fertile females. Clinical signs include papilledema and headaches. And that's why you always want to ask patients on tetracyclines about headaches, as this is the first sign they'll show up. Papilledema results from intracranial pressure exceeding eye pressure. And that's when intracranial pressure is above 200 millimeters of water. The papilledema is likely due to improper reabsorption of cerebrospinal fluid due to sinus stenosis, and that's how the intracranial pressure increases. Some sources cite that if you lose 10% of your body weight, that it will resolve. The way that tetracyclines work is they can enter the cerebrospinal fluid, but usually don't have any efficacy here. And that's with the exception of minocycline that does. And that's the reason that minocycline is documented in the literature for causing PDC more than any other tetracycline. It is believed that tetracyclines have toxic effects on arachnoid villi, and that results in the reduction of cerebrospinal fluid reabsorption. This is just a representation of what the sinus would look like. You can see the sinus, the clear space in the middle, has arachnoid villi sticking into it, and then that arachnoid villi drains the cerebrospinal fluid into the subarachnoid space. Next drug up is haloperidol. Haloperidol is a first-generation antipsychotic. Those are set aside from the second generation in terms of receptor selectivity and region of efficacy in the central nervous system. The systemic condition it treats is neuroepilepsy. It's characterized by recurrent seizures. This can be associated with high dopamine levels and results in a synchronous discharge of cortical neurons. There are many kinds of seizures. Tonic-clonic is what most people think about when they hear the word seizure. That can include dramatic loss of consciousness, convulsions, incontinence, or amnesia of the event afterwards. The way that this class acts is it's a dopamine receptor antagonist. So it reduces the ability of dopamine to create action potentials because it decreases the amount released. It also has alpha-1 receptor antagonists, and that's what we're concerned about. And that's why the ophthalmic side effect can be constricted pupils. Now, constricted pupils are obviously a normal response to well-lit environments and near targets, and that's primarily mediated by parasympathetics in cranial nerve 3. This is a picture of the parasympathetic pathway for pupil constriction. As you can see, the afferents leave the optic nerve head, travel along the nerve, hit the chiasm, and then along the optic radiations it actually breaks off and goes to the pretectal nucleus. This will decusate, go to the Edinger-Westphal subnucleus of cranial nerve 3, and efferently go back to the pupil to have it constrict. So this drug doesn't act directly on the parasympathetic pathway. We'll discuss later the sympathetic pathway, but alpha-1 sympathetic receptors are sensitive to drugs like phenylephrine. Phenylephrine stimulates the iris dilator to make the pupil larger. Phenylephrine is then an alpha-1 agonist, but drugs like haloperidol can do the opposite, or can block the binding of norepinephrine. This decreases the innervation to the iris dilator, allowing for more parasympathetic tone or constriction of the pupil. The last drug we'll talk about are hemorrhoidal creams. Active ingredients for these are proxamine, phenylephrine, hydrocortisone. Proxamine is a topical anesthetic. Phenylephrine is an alpha-1 agonist that causes vasoconstriction. That's important. Hydrocortisone is a steroid. Now they also have glycerin for lubricant and petroleum for the base, but there are various formulations, but these seem to be the what's common in all of them. The systemic conditions it treats is hemorrhoids, also called piles. They're swollen and inflamed veins in the anus and lower rectum. They can either be internal or external. External can be visualized without endoscopy, and it can result in painless bleeding during defecation. Also, they can cause itching and discomfort. Common causes of hemorrhoids are obesity, pregnancy, and low-fiber diets. Now, the one that we're concerned about is phenylephrine. It binds alpha-1 receptors to increase sympathetic tone. Proxamine decreases the neuronal membrane's permeability to sodium ions. That can reduce the action potentials and lengthen refractory periods for the pain. And hydrocortisone inhibits release of arachidonic acid and reduces COX-2, both important in the inflammatory cascades. What it can show up at the ophthalmic side effect is dilated pupils. Here's a picture of the pathway of the sympathetic pupillary pathway. It starts in the posterior hypothalamus, travels in the spinal cord, synapses in the spinal cord, then it'll leave the spinal cord as the presynaptic neuron, synapse in the superior cervical ganglion, and leaves as the postsynaptic neuron, and will travel with the internal carotid artery to the iris dilator. The way that this works is it has phenylephrine in it. Phenylephrine can act like norepinephrine. Now, a lot of the sources state the necessity of washing your hands before and after use of a cream, such as Preparation H. Failure to do this could result in hand-to-eye contact of the cream. If it's through this mode that phenylephrine can get into the eye, it'll act like an alpha-1 agonist, just like a drop would. This will increase sympathetic tone and cause a pharmacological increase in pupil size. This could be made worse. Like I said earlier, phenylephrine is a vasoconstrictor. There's a myth that if you put these on the bags of your eye, that they'll reduce. And this is just going to increase the chances of the cream actually entering the eye.
That concludes the drugs we're going to talk about in the presentation, but we want to wrap things up with just a few important points. Number one, be able to recognize a neuro case when you have it. It's always important to determine what medications your patient is taking, but with a neuro case, it's crucial. Number two, recognize drugs that have common ophthalmic side effects, and not just the ones that optometrists prescribe, but other physicians as well. And then lastly, although neuro-ophthalmic side effects from medications are typically rare, they still happen, and it's not rare if it's sitting in your chair. Finally, these are the sources that we used for our presentation.